Welcome back. This is management part of our ischemic stroke series. After this video, we will be able to solve this type of questions. So, let's start. In previous one, we covered diagnosis, complications, and secondary prevention, but this time we're focusing on the acute management. When a stroke patient arrives, start with general supportive measures before specific treatments. First, ensure airway breathing and circulation are stable. Provide oxygen only if the patient is hypoxic with oxygen saturation less than 94%. Routine oxygen supplementation is not recommended. Establish IV access for medications. Start cardiac monitoring to detect arrhythmias like atrial fibrillation. Keep the patient MPO until swallow assessment is completed to prevent aspiration. Position the head of the bed at 30 degrees. Reperfusion therapy is the cornerstone of acute ischemic stroke management. There are two main approaches: IV thrombolysis with tPA and mechanical thrombectomy. tPA, or tissue plasminogen activator, works by dissolving the clot. It's indicated within 4.5 hours of symptom onset for ischemic stroke with measurable neurological deficit and when there are no contraindications. So, to be included, patients must be 18 years or older, have a clinical diagnosis of ischemic stroke, have measurable neurologic deficit, and have a clearly defined time of symptom onset. Major contraindications include intracranial hemorrhage on CT, recent major surgery within 14 days, recent stroke within 3 months, active bleeding, uncontrolled blood pressure greater than 185/110, and glucose less than 50 or greater than 400. The dose is 0.9 mg per kilogram with a maximum of 90 mg. Give 10% as a bolus and 90% as an infusion over 1 hour. During infusion, perform neurochecks every 15 minutes. Monitor blood pressure closely. Watch for complications, including hemorrhagic transformation. Mechanical thrombectomy physically removes the clot. It's indicated for large vessel occlusion, including internal carotid artery, MCA segments, and basilar artery. The time window is within 6 hours, though it can be extended up to 24 hours in selected patients with favorable imaging. It can be combined with tPA. The procedure uses an endovascular catheter with either a stent retriever or aspiration device to physically remove the clot. As advantage, mechanical thrombectomy has higher canalization rates for large vessel occlusions compared to tPA alone. It also has an extended time window when patients have favorable imaging, such as good collateral circulation. Blood pressure management in acute stroke is nuanced and depends on whether the patient is a tPA candidate. If the patient is receiving tPA, the target is less than 185/110 before administering tPA. Maintain blood pressure less than 180/105 for 24 hours post-tPA. Use IV labetalol or nicardipine for rapid control. If the patient is not receiving tPA, we practice permissive hypertension. This means we allow higher blood pressure because the brain needs perfusion to the penumbra. Penumbra simply means surrounding area of damaged tissue. Only treat blood pressure if systolic is greater than 220 or diastolic is greater than 120, or if there are comorbidities requiring lower blood pressure such as aortic dissection or acute MI. When you do lower blood pressure, do it gradually and only 15 to 25% in the first 24 hours. Start antiplatelet therapy within 24 to 48 hours after ruling out hemorrhage on repeat imaging. Do not give antiplatelet if tPA was administered, and wait 24 hours after tPA before starting antiplatelets. For most patients, give aspirin 325 as a loading dose and then 81 to 325 daily. Alternatively, use clopidogrel 75 mg daily. For minor stroke or TIA, do antiplatelet therapy with aspirin plus clopidogrel for 21 days has been shown to reduce early recurrent stroke risk. Anticoagulation is indicated for cardioembolic sources, such as AFib or mechanical heart valves, However, do not start anticoagulation in the acute phase. Wait at least 2 weeks due to the risk of hemorrhagic transformation. Options include warfarin with target INR of 2 to 3, or direct oral anticoagulants, including apixaban, rivaroxaban, or dabigatran. Okay, let me summarize the management approach. First, on arrival, start general measures. Obtain CT scan immediately to rule out hemorrhage. If within 4.5 hours and no contraindications, give tPA. If large vessel occlusion and within time window, perform mechanical thrombectomy. Manage blood pressure based on whether tPA was given. Start antiplatelet therapy after 24 to 48 hours. Consider anticoagulation for cardioembolic sources after 2 weeks. This completes our 2-part series on ischemic stroke. Thank you for watching. If you found this helpful, please like and subscribe, and check out part 1 if you haven't already.